Hello, everyone. My name is Lourdes. Welcome to our Thursday webinar series. Happy to have you here with us today. As a reminder to everyone who is watching, please make sure that you enter any questions you have on this particular topic into the chat or the Q&A, and we will ask your questions at the conclusion. We do want those questions to be general in nature, as our speaker is not able to answer specific medical questions that you may have. I would like to introduce Milind Javle. He is a clinician, educator, and investigator with over 15 years experience in treating cholangiocarcinoma. He is an attending physician and Ruth and Olive Stringer Professor, GI Medical Oncology at the University of Texas MD Anderson Cancer Center. He is also the chair of the NCI Task Force in the Hepatobiliary Cancers, clinical medical director of GI Service Line at MD Anderson, and the former chair, International Cholangiocarcinoma Research Network. He is an advisory member for the Cholangiocarcinoma Foundation and the co-chair for the Southwest Oncology Group, SWOG, Hepatobiliary Committee. Thank you for being here, Dr. Javle.
Thank you very much, Lourdes. Actually, I think I've been doing this, treating the disease for over 2 decades now. So the topic here is one of great interest to me, and I hope to the audience as well. It's titled Targeting Tomorrow: 2 agents, 3 targets with next generation of immunotherapy, which is rilvegostomig, a TIGIT-directed checkpoint inhibitor, plus T-DXd, also known as HER2 for advanced biliary tract cancer. So welcome to this webinar. We all know that cholangiocarcinoma is increasing. On the left, you see a figure from a national database. The blue line represents intrahepatic cholangiocarcinoma, which shows a rapid increase. In terms of prognosis, the patients who are diagnosed with cholangiocarcinoma tend to have a better survival as compared with those who may have cholangiocarcinoma but are diagnosed as something else, such as cancer unknown primary. And at MD Anderson, on the right, you see the numbers of increasing patients that we see. That is true for every institution. The numbers that we see are increasing annually. And in terms of treatments that are offered, 85% or so get first-line therapy, about 46% get second-line therapy, and 17% get third-line therapy. So we are talking of a disease where our best shot for treatment is probably in the first-line setting. However, I want to reassure the audience that there are options in subsequent line that are changing and improving each year. So this is a rapidly changing and evolving field. In pre-2010, an era to which I belong, we had very limited options. And then since then, we've had several therapies, the first being gemcitabine and cisplatin, which was approved on the basis of the ABC-01 trial. In Asia, a drug called S1, a second-line FOLFOX, and then really a lot of progress in the targeted therapy group arena in the form of FGFR inhibitors, IDH1 inhibitors, with NALIRI, and several other agents that are since then approved in not necessarily FDA approved, but have NCCN designations. Over the last 3 years, it's been even more exciting with the advent of immunotherapy, with the approval of durvalumab and pembrolizumab in the first-line setting. So the first immunotherapy or checkpoint inhibitor trial, it was a first-line study of 635 patients who were treated with gemcitabine and cisplatin plus durvalumab versus gemcitabine and cisplatin plus placebo. And these patients received this therapy for 8 cycles or 6 months, followed by maintenance durvalumab or placebo. The primary endpoint of the study was overall survival, and this primary endpoint was met. As you see in the red line, there was an improvement as compared with the addition of durvalumab as compared with a placebo when given with gemcitabine and cisplatin. And this improvement was sustained over time. So at 2 years, over almost a quarter of patients were doing well with durvalumab, and this, what we call a tail in the curve, or continued benefit from this therapy over time. These are some patients from this is a patient from my own practice. You see a coronal view. That is, a patient is standing in front of us. You see the liver. I'm not sure you can see my arrow, but the large lesions that you see in the right lobe of the liver, and with the addition of durvalumab to gemcis, very nice response. And this patient subsequently underwent surgical resection, an outcome which we rarely saw in the past. So these types of examples are now increasing in our practice. And this was importantly achieved without significantly worse toxicities. If you look at the treatment-related adverse events, they were relatively similar in both arms, with or without durvalumab, with the exception of course, immune toxicities such as diarrhea, skin rash, which are higher with durvalumab. A year later, there was also approval of pembrolizumab in a similar study, when it was combined, Keytruda combined with gemcitabine and cisplatin. And then in the maintenance phase, after 6 months or 8 cycles, patients received gemcitabine plus pembrolizumab. So there was some difference in the study. However, the outcome was positive, and we're very excited to have 2 frontline agents for our patients in immunotherapy. On the other hand, additional chemotherapy did not help. The SWOG 1815 trial included gemcitabine, cisplatin, and nab-paclitaxel, known as with the brand name as Abraxane, compared with 2 chemo agents like gemcitabine and cisplatin. So more chemo was not helpful. So while we were disappointed with the result, however, in a way, I'm glad that more chemo is not the answer, and that toxicity of 3 agents can be prevented by using immunotherapy instead of a third chemotherapy drug. Now, we have known for several years, and this is a study now over almost a decade ago, where we looked at the kind of mutations that are seen in intrahepatic cholangio, that is ICCA, extrahepatic cholangio or ECCA, and gallbladder cancer, that's on the right. So this, you see the kinds of mutations differ between the 3 kinds of biliary tract cancer. When you look at HER2 or ERBB2 gene amplification being multiple copies of the same gene, they are highest in gallbladder cancer, followed by extrahepatic cholangio and then intrahepatic cholangio. These results highlight the fact that we can now target this ERBB2 gene, also seen in breast cancer, more commonly than most other cancers, but really quite a high incidence in gallbladder cancer. But even besides that, the larger point I'd like to make is really important to get genetic profiling in all our patients, so that patients may hopefully have an option for targeted therapy. And these are some of our early results with one of the first drugs in the space, trastuzumab, which has been around really for over 3 decades for treatment of this HER2 positive breast cancer. We use that in combination with chemotherapy. You see a mass in the liver next to the gallbladder, which is highlighted by the arrow in the figure A. And in B, after treatment with trastuzumab and chemotherapy, you see a nice reduction, also seen in panels C and D, improvement in lymph nodes. So the lymph nodes seen in panel C and D makes the cancer metastatic. Yet in this case, the patient also ended up having surgical resection and had a long survival with targeted therapy. So these kinds of preliminary data form the basis of additional trials. One of the study done by a group was trastuzumab and pertuzumab. This is a drug targeting 2 particular domains of the same protein, called the HER2 binding domain, trastuzumab binding domain, and the pertuzumab binding domain. And it showed a nice response rate. These responses were sustained in about a quarter of patients without much toxicity. with the antibody or tolerable side effects. And this agent received NCCN designation about 3 years ago. There are several such drugs targeting HER2 in biliary tract cancer and other cancers. The one that I'm going to focus on is trastuzumab deruxtecan, or known by the acronym T-DXd. So this is a group of drugs called antibody drug conjugates, where there's an antibody, which is in this case an anti-HER2 antibody, IgG1 antibody. It has a linker which connects it to a chemotherapy payload, topoisomerase 1, exatecan, a kind of drug which is similar to TIGIT. So this drug was devised to deliver the payload, that is the topo-1 isomerase inhibitor, the chemotherapy backbone, to the HER2, to the ERBB2 or HER2 new receptor. So there are some characteristics of this molecule that are described on the right, in the table on the right. It is a very potent molecule. It has a short half-life. It has the linker actually is of great importance in delivery and the activity of this drug. And it has a bystander effect. So this was a study of all tumors done by my colleague, Dr. Van der Merk, where she looked at a variety of tumors that have HER2 amplification and HER2 overexpression. So by that I mean that the expression of the protein HER2 was high in the tumor, typically described as 3 plus, also as 2 plus, and these were included if they had 2 plus with positive FISH. And a nice signal was seen in several cancers described here. There is cervical cancer, endometrial cancer, ovarian, bladder, and other cancers, also seen in purple right in the center. In biliary tract cancer, where patients whose tumors had 3 plus overexpression had a response rate of over 50%. So this is what got us all excited, and these were really sustained responses. So you see that those who had 3 plus had a median duration of response of almost a year. 2 plus, along with FISH, had also a response rate, but that was lower. In other tumors, there were not enough patients seen with biliary tract cancer that were enrolled, but the signal was not strong in biliary tract cancer, at least in the small number that were enrolled in the study. So these kinds of encouraging data have led to a subsequent trial that I will describe in the main part of our discussion today. So first of all, what percentage of patients with biliary tract cancer are HER2 expressing? I mentioned earlier that it's more seen in gallbladder cancer, extrahepatic, and then intrahepatic cholangio. If you group them all together, it's about 9% are HER2 3 plus, and those that are 2 plus and ISH positive are about 5%. Those that are HER2 positive 2 plus without ISH are maybe much higher number, that is 22%. For the most part, we are going to focus on these 9% that are 3 plus, and the 5% that are 2 plus and FISH positive. The other point I want to make is PDL1, the checkpoint, along with TIGIT, which is a newer checkpoint that is being investigated in clinical trials. It is expressed together. So TIGIT or CD155 is expressed in about 61% in cholangiocarcinoma. It is correlated with a aggressive tumor behavior. And you see several figures here on the right, which shows that it is positively correlated with PDL1. So if PDL1 is elevated, this checkpoint, TIGIT, is also overexpressed at the same time in majority of patients. And the molecule that is being developed in this space is called rilvegostomig, or AZD2936. This is again a bispecific molecule which acts against PD1 and it acts against TIGIT. So it's a humanized IgG1 antibody. It has a PD1 targeting arm and it has a TIGIT targeting arm. And there are some very encouraging data with this new molecule, which is, I think, the next generation of checkpoint inhibitors, like beyond, say, durvalumab and pembrolizumab, which targets two different moieties that are described here. And there is good rationale why we should combine T-DXd with anti-PD-1 plus anti-TIGIT. This basically is a preclinical study showing that the antitumor effect is better if you combine the two as compared with the Enhertu or T-DXd alone. So the combination of these T-DXd and HER2 plus this new molecule, rilvegostomig, was more effective than any of those used alone. And in fact, this has been investigated in other disease types that I'll describe in the next couple of slides. This one is in lung cancer in a phase 1/2 trials. The forest plot, you see the vertical green and the yellow line bars that you see show a nice response, an overall response rate 61%, in fact, in patients with lung cancer having HER2 overexpression. There has been a phase 2 trial, a smaller phase 2 trial in first-line biliary tract cancer, the Gemini hepatobiliary trial, in which the indications for the trial are described here on the left. About 30 patients with metastatic biliary tract cancer have been enrolled on the trial. And in this study, patients were treated with gemcitabine, cisplatin, and rilvegostomig. And this was a single-arm trial, so you can't really compare necessarily with what happened, how it compares with, say, the Topaz-1 regimen or the Keynote 966 regimen. But certainly in this smaller study of 30 patients, it showed a very encouraging signal that we hope will go forward. So this is a slide summarizing the antitumor activity of rilvegostomig. That is a Gemini hepatobiliary trial. There's also an ongoing trial, the Artemide-BTC, the biliary 01 trial, which is an adjuvant trial. So patients who have surgical resection get this rilvegostomig in combination with chemotherapy in the post-operative setting as compared with chemotherapy alone. And there's no safety signals have been identified, and the study is accruing very well. Hopefully, we might see a new signal for checkpoint inhibitor in the post-operative or adjuvant trial after completion of the Artemide-biliary 01. But the study I'm going to talk about mostly in the next few slides is a Destiny-BTC-01 trial in the box here, which is a phase 3 trial for HER2 overexpressing biliary tract cancer. This trial is a 3-arm trial that I'll describe later for biliary tract cancer, that is HER2 3 plus or 2 plus and ish overexpression. And they have already finished a safety cohort of 23 patients in this phase 3 trial, and the toxicity was thought to be manageable. The safety committee made some recommendations based on the early results to improve safety. And it is being this combination, this checkpoint inhibitor, rilvegostomig, is now being evaluated in multiple phase 2 and phase 3 trials. In fact, 20 trials in various disease types that are described here, such as lung cancer, stomach cancer, biliary tract cancer, etc. The one we will talk about in the next slide is the Destiny-BTC-01 trial, which is the trial that is currently ongoing. We'll describe some of the mechanics of the trial, who are the patients who are enrolled in the trial, what arms, and what we are looking for. The study is sponsored by AstraZeneca, and Dr. Saeed, who is the medical lead for this trial from AstraZeneca, is also on, and we're going to try to answer any questions you may have in regards to this trial. So the eligibility for the trial are described here. Patients with advanced biliary tract cancer, that is cholangiocarcinoma, intrahepatic, extrahepatic, or gallbladder cancer patients are enrolled. In the first-line setting, these patients should not have received any prior chemotherapy in the first-line setting for advanced cancer. They are If they had surgery, then at least 3 months should have passed. Patients should have 3 plus, the tumors should be 3 plus, or immunohistochemistry or 2 plus with FISH, measurable disease, and ECOG performance status. A good performance status is required for enrollment. Safety run-in of 23 patients has already completed. And this trial will enroll 600 patients with 3 arms. The first arm that I mentioned earlier will be T-DXd plus rilvegostomig. About 200 patients will receive this HER2-directed therapy plus this new checkpoint inhibitor. The second arm will receive the antibody drug conjugate or T-DXd alone. And the third arm will receive the standard treatment arm for TOPAZ-1 with gemcitabine, cisplatin, and durvalumab. The primary endpoint of the trial is overall survival, and the secondary endpoints are standard, including response rate, progression-free survival, duration of response, and safety, patient-reported outcome. The stratification factors for the trial are HER2 3 plus versus 2 plus, PD-L1 status, and the primary tumor location. The study is actively ongoing at this time. So as I mentioned, the safety, the 23 patients in the first safety run cohort, this has already been completed. Based on the side effects that were noted in the first run-in, there have been mitigation strategies to prevent any further serious toxicities such as infections. And the recommendation by the safety committee described point A being if they had any infections, then they have to complete the course of antibiotics before a randomization to either of the arms. And then point B being that the patient should be confirmed by the investigator to have adequate biliary drainage prior to randomization. In some cases, we will allow growth factors such as white cell growth factors to prevent count suppression and serious infections that may result from chemotherapy. There are other factors that other mitigating strategies that have been proposed as well to make this therapy safe for the patients. So as I'm going to go again and review the key inclusion criteria for the trial, that is, who are the patients who will be allowed to be enrolled. These are patients with previously untreated biliary tract cancer, locally advanced or metastatic. They should have positive, the tumor should have positive HER2 expression, that is 3 plus or 2 plus. There is a good performance status of ECOG 0 or 1, at least one target lesion that can be measured, and adequate bone marrow function, adequate laboratories that are described here, and patients are to have a good physical and condition to tolerate these therapies. These are some of the exclusions, which are any prior treatment for metastatic disease, if patients who have prior HER2-directed therapies. This is a biliary tract cancer, so patients with ampullary cancer are not included. Patients who have active autoimmune disease or inflammatory disease and cannot get immunotherapy, any immune deficiency syndromes, lung diseases, because this may be some of the toxicities of these therapies, interstitial lung disease in particular, other cancers, cord compression, and uncontrolled infections. These patients are excluded for safety reasons. This graphic describes the patient journey on this trial. So patients who are referred to the trial, they undergo a screening process to evaluate eligibility on all the criteria. For safety, if they could be rescreened to make sure that they remain eligible after their HER2 results are back. They have to have a HER2 result which is centrally tested, and the turnaround time is usually quite short, about 5 days to get the result. And if HER2 positive 3 plus 2 plus, they start treatment as indicated, cycle 1. They get reevaluated every couple of cycles with CAT scans, and then the treatment is completed until progression. There are some end of treatment evaluations and safety evaluations that will follow. Because T-DXd sometimes can lead to interstitial lung disease, They have very close lung monitoring during this trial. This is a global trial that I mentioned, about 600 patients, one of the largest trials in biliary tract cancer of targeted therapy. And these are the countries which the trial is currently open: North and South America, some parts of Europe, Middle East, and Asia, and Australia that are described. So we are very excited to be a part of this journey for patients and hopefully a novel targeted therapy that may be advanced in the frontline setting. So this is really what completes my summary. I'm happy to answer any questions. Said is here with me from the company as well. We'll try to answer any sponsor-related questions. Thank you, Lourdes, for inviting me and asking me to be a part of this important seminar.
Thank you, Dr. Javle. Anyone who has a question, please feel free to enter it into the chat or the Q&A, and that way we can ask those questions here. I have a question while we wait for some folks to enter in. I know you mentioned that an exclusion factor would be any other types of cancers in addition to biliary tract cancer. Would that be an exclusion as well if somebody had a prior cancer but is now in remission of that particular type of cancer?
Yeah, they will not necessarily be excluded, Lourdes, if there are certain cancers that will not impact on the evaluation of the current cancer. That will be permitted if the tumor is in remission. Yes, so not necessarily in all cases will they be excluded.
Okay. I still see no questions from our community. I saw the 3 different arms. Is it possible for a crossover if somebody is enrolled in the standard of care treatment and they have progression? Would they be eligible to do a crossover? Or is that not part of this particular clinical trial design?
Yeah, this is not a crossover design, but I'm going to ask Said about, is there an ability to get this drug later on in some other form if the patients did not have access to those drugs in the frontline setting, expanded access programs from AstraZeneca and so on?
Perfect, thank you. Can you share what was the rationale for combining the rilvegostomig with the T-DXd versus a bispecific HER2 drug like zanidatamab?
Versus what? The bispecific drug like zanidatamab? Is that the question?
Correct, yes.
Right. So, I mean, these are two different trials. I wouldn't like to say that T-DXd is better than zanidatamab or so on. I think zanidatamab is an effective drug. The rationale here is that the same molecule has a chemotherapy backbone as well as an antibody that directs that chemotherapy backbone to the tumor. Zanidatamab is a bispecific antibody. It does not have any chemotherapy backbone. So there are different mechanisms of action. Of course, the rationale for this drug, for this agent, is to, investigate the use of T-DXd in the absence of gemcitabine and cisplatin. So it's really quite a different drug, a different mechanism of action, and a different kind of trial. I wouldn't want to say that that one is superior to another.
Okay. Should a patient be included if the cancer is in remission with no sign of recurrence in scans or labs?
Sorry, Lourdes, can you repeat it? Repeat the question?
Should a patient, or maybe could a patient be included if the cancer is in remission with no sign of recurrence in the scans or labs?
Right. Well, that patient would not be a candidate for this trial. This trial is meant for patients who have active metastatic disease, and that needs to be controlled with therapy. So if the patient has, for instance, received some prior therapy for biliary tract cancer, there's no active cancer, no measurable disease, there's no reason for this sort of trial at that point.
Okay. Is it possible that rilvegostomig will be fast-tracked by the FDA for approval?
So the Saeed, could you answer that question? I'm not sure that there is any fast track uh, application for this for rilvegostomig at this time.
Thank you. I mean, that depends on the data, of course. We don't have any, so we've got a lot of ongoing studies at the moment. As you've seen, as Dr. Javle presented as well, we've got 20 ongoing, including 10 phase 3 studies, registrational studies. I think, depending on the data, we will see. So we can't really say anything about that. It's data-driven and based on agencies' feedback. Yeah.
Thank you.
Yeah. So Saeed, for instance, you have the post-operative adjuvant study that is ongoing that began a while ago prior to this trial. And hopefully you might get a signal from that study, which is positive in the post-operative setting. So there may be a possibility there. We are always hoping for new drugs, but it's although biliary tract cancer is a different indication. So we're always looking forward to that result.
Thank you. If people are not HER2 positive, would the drug still work, say non-specifically? How specific is the HER2 antibody?
So in the initial pan-tumor trial that I described, there were no responses in patients who didn't have any HER2. This drug is really meant for patients who have HER2 3+, and there may be some activity in 2+ that are FISH, but it's not indicated or shouldn't be investigated in the absence of any HER2 expression.
Okay. If a tumor analysis has described the ERBB2 amplification as equivocal, should the patient be included in the trial?
So I would encourage all patients to be screened for HER2 overexpression by immunohistochemistry. I think you would think that amplification high or would definitely be a candidate, and amplification equivocal may not be a candidate. I'm finding in my practice that the correlation between amplification and overexpression by immunohistochemistry is not as straightforward as one may imagine. So I would say that if there is a real interest, it's best to have the patient screened for immunohistochemistry and see if they are a candidate. Saeed, do you want to add anything here?
Just one thing, actually, one of the differences between Destiny BTC01 and external trials in HER2 space, first-line BTC, is actually we're including those HER2 equivocal as well, ish equivocal, HER2 IC2 plus ish equivocal patients as well. So we're trying to be more inclusive to include those with HER2 IC3 plus and 2 plus irrespective of ish in our Destiny BTC01 trial.
Thank you. Would someone who had recurrence after stage 4 inoperable BTC and in the liver, would they be eligible for this particular trial?
Yes. Mm-hmm. So this can be locally advanced or metastatic. And so if this patient has inoperable locally advanced BTC, yes, they could potentially be eligible depending on the HER2 expression.
Okay, thank you. What is your opinion on why prior TIGIT therapies have failed in the clinic, and what makes you think this particular approach with rilvegostomig will produce a different result?
Yeah, I think that this is a different indication. We know that when it was combined with T-DXd and the TIGIT directed was rilvegostomig was combined with T-DXd, there was an incremental effect, that is, anti-tumor effect in the lab was better. I want to remind the group that, for instance, there were several single agent trials with immune checkpoint inhibitors like nivolumab, pembrolizumab, etc., that did not look promising. Whereas when it was combined with GemCis in the Topaz-1 trial, the Keynote trial, the study ended up being positive. So there's a lot that we are learning in with the use of checkpoint inhibitors that we didn't know before. So you will see, not every disease is the same. We are seeing an encouraging signal with TIGIT, like I mentioned in the Artemis trials, as well as in the early activity seen in the preclinical setting. So it remains to be. I think the question is still open in many diseases, not just BTC.
For anyone who is new to cholangiocarcinoma and this diagnosis, can you explain how to be tested for HER2?
Yeah. So HER2 is testing is really available all over the world. It is one of the first targeted therapies in cancer. I want to say almost over 3 decades ago in California, there was a team that developed a test against it with immunohistochemistry. So it is done, with a group of slides tested with immunohistochemistry, a very simple standard procedure available all over the world. But the methodology can vary between different disease sites. So for this trial, it has to be centrally tested. So patients who have a biopsy, those slides are shipped to the company, to a central vendor, and they evaluate the HER2. And if the patient is then positive, that signal is transmitted to the investigator, and the patient can be enrolled. So while the test is locally available and can be measured for evaluation on the trial, because there's a lot of discrepancy in results sometimes between pathologists. So for the trial, it has to be centrally evaluated.
Thank you. Does the BTC-01 trial performed any transcriptomic sequencing of the tumor tissue samples? I'm not sure what that means, but maybe you do.
So I think they're looking for gene expression or transcriptomics. I don't know if I understand the question, but there are many platforms which show gene expression, like they'll say overexpression based on mRNA or RNA sequencing, and that's promising, but that's not necessarily an inclusion criteria for the trial. We still have to do immunohistochemistry. I see patients, we use a platform in our institution where we look at genes as well as look at gene expression using transcriptomics. If it is high with HER2, certainly I'm encouraged, but I can't enroll patient based on that. They need the central testing using IHC to be eligible.
Okay. Can you share how many of the 600 trial spots have been filled, or how many more are you looking for to complete the trial?
Yeah, so I'd let Said answer that. I mean, keep in mind that the study is open. It's open all over the world. There are certain confidentiality aspects to these data, and I'll let him comment.
I don't think I can comment more than that. I mean, we're actively enrolling globally, of course, and activating sites as we speak. And of course, we're enrolling in some of the regions more quickly than others, but actively enrolling globally. That's what I can say at this stage.
Okay. Can you share how a patient would contact the site or contact AstraZeneca? Can you share a little bit about how they can, ask how to participate in this particular trial?
We have local team and SMMN team that are actually they can contact, and and the local leads as well at different sites. Regionally, they can contact and get information about study and the eligibility. Yeah.
Yeah, I want to mention, Lotus, that I presented earlier that the safety cohort of 23 has been completed, and now we are in the randomized phase and accruing well. Said, I have a question for you. A lot of patients here at MD Anderson and many other sites, they travel. There are, a lot of logistical issues with participating in the trial. Is there any assistance that the company might provide to those patients to make this their participation a little more convenient?
Yeah, absolutely. I mean, we can look into that internally and facilitate that for patients. We understand that it's not easy for them to travel, especially in the US. I think it's going to be more of a problem, or in some countries like China, US, for instance. Yeah, absolutely.
Yeah, I think, Lotus, I want to mention that I can't speak for the company what will be covered and what will not be covered, but I've seen in my practice and in places that have other sites around the world where, it's hard for people to travel and lodging, etc. These are things that an individual site can sometimes work with the sponsor. Of course, they have to get an approval from their institution review board, etc. But I found that they are very willing to assist in whatever local regulations will allow them to do.
Thank you. And thank you for asking that question, Dr. Javle. I don't see any other questions come up from those who are watching, but if anyone else has any other questions, please feel free to enter them into the chat. I appreciate you both for helping with this webinar and sharing this information. Someone would like to know if Saeed can respond or comment on articulating why this TIGIT approach is differentiated.
That's actually a great question. So not all TIGITs are the same. So as you know, I mean, we've got a lot of different anti-TIGIT basically in development. So our rilvegostomig, as you know, as also Dr. Javle beautifully presented, is a FC-reduced monovalent bispecific antibody that kind of enables the localized and coordinated inhibition of both PD-1 and TIGIT. And that dual kind of blockade by this bispecific increases the CD8 T cell immune activation, basically. So that way we also looked at this co-administration of anti-PD-1 and anti-TIGIT and compared that with our bispecific strategy. And it looks like the bispecific mode of action actually promotes CD8 T cell activation more than mono PD-1, anti-PD-1 and anti-TIGIT co-administration. Also FC reduced aspects of it while maintaining basically the efficacy or enhancing the efficacy of basically immunotherapy also would provide a favorable safety profile because basically the overall safety and efficacy remains favorable when you use FC reduced or FC silent basically anti-TIGIT, anti-PD-1 bispecific. Whereas in other anti-TIGIT, external anti-TIGIT and anti-TIGIT monoclonal antibody, we have some FC active that monoclonal antibody interact with various FC receptors and then that trigger effector cells and ADCC basically, which creates a lot of toxicity as well. So that's why we think this FC reduced strategy in a bispecific monoclonal antibody would maintain the safety or improves the safety and at the same time increases the activity of this immunotherapy. And when it's combined, as also Dr. Javla mentioned, with T-DXd, we've seen some depth and duration of the responses in the tumor.
So, Lotus, I explain it to patients. I say, when they say, well, why would this molecule work, rivastomig, when you already have PD-1 approved drugs, right, like pembrolizumab or durvalumab, that patients can be used. So the way I describe it to them was, as Saeed described very eloquently, that it is bispecific. It does that, plus it targets another protein, TIGIT. So this therefore you get more than just PD-1 or PD-L1 inhibition. Now, how effective that will be, we will see, but it's not a typical TIGIT molecule that has been investigated in the past. It's a bispecific. So we hopefully have advantage of dual inhibition that we didn't have before.
Thank you both to answer that question. I know that you showed the map of where this is recruiting, but for our Canadian patients, are there any sites in Canada? And if you can just share maybe which those locations, or even show the map again, that would be helpful.
Sure, I'll go to the map again. And yes, Canada is very dear to me because I have family there as well. And I hope that we will so Saeed, we see the entire North America over there. What do you have to say about Canada?
Yeah, absolutely. I mean, we definitely have, and Canada actually participated in our safety running phase as well. So of course, the randomized part was contingent upon the safety of this combination and based on the IDMC recommendation. And we recently got approval locally in Canada, so we are activating more sites in Canada. We actively enrolling as well. We started actively looking for patients in Canada as well. Absolutely.
Perfect. Thank you so much. I don't see any other questions. So I want to just thank you both again for this information, this webinar, and helping our community understand a little bit more. We appreciate it.
Thank you, Lotus.
Thank you.